Hello, thank you for joining us. My name is Tiffany Conroy. I'm one of the steering group members for the International Learning Collaborative, and I'm delighted to be joined today by Mette Adams. Anne's going to talk to us about what her PhD is done or doing, how the fundamentals of care are assisting her with that, and how the ILC is assisting her with that. So, Mette, would you like to introduce yourself, please?
Yeah, thank you very much, Tiffany. So I'm Mette Adams, and I'm a teacher at Flinders University, and I'm currently doing my PhD. I did my Bachelor of Nursing back in 2003 in Denmark, and since then I've worked in different healthcare settings in Denmark, Norway, and Australia, and mainly in the intensive care units. So I think when you travel a lot, you see different levels of care. And you start to notice when you see excellent care and you see nurses doing something and you think, wow, that's great. I want to be able to do like that. And then you see also when care is perhaps not optimal, when it's not good enough, and you start to think, I think we can do better. So I think when I started to hear about the fundamentals of care framework, I thought, yeah, this is something that we need. It seems so basic, it seems so simple, but really it's we don't always get it right. And sometimes it's because we don't have time and resources, but sometimes it's, I think, because we don't necessarily fully understand what it looks like, or we don't fully understand how to prioritize it.
Now, you've had a lot of experience working in intensive care units, both in Australia and in Denmark, and some other countries, I believe. Tell me why you think, or what you think it is about the fundamentals of care that's relevant in the intensive care unit.
Yeah, so I think the framework is extremely relevant, first of all, in the intensive care unit, possibly more relevant than in other healthcare settings that I know of. And it's because patients are so vulnerable. I mean, they need our help with everything, with all of their needs. They are at risk of dying. They may be confused. They often have a breathing tube in their throat, so they can't talk. So we need to support them and help them through. And I think in particularly developing that relationship of trust that's very central for the fundamentals of care framework, I think that's extremely important that we are able to develop that. And I think, to be honest, sometimes that can even save lives.
Wow, okay. Well, I mean, we'd agree with you, obviously, because we think that, fundamental care is absolutely relationship-based. But it is a tricky environment. And tell me, how would you suggest people try and maintain or develop those relationships? Because I know your interest is on preventing and managing patient agitation in intensive care.
Yeah.
So tell me how you think the relationship might make a difference, and some strategies perhaps that people could use to do that.
Okay, so I guess I can mention a couple of examples of where it's very difficult to create that relationship of trust, and areas where perhaps I feel we could do a little bit better. And so, for instance, one area is around physical restraints. It's fortunately something that's not being done in all intensive care units, but it is in some. It's something I've always found really difficult, and perhaps particular those patients who are extra vulnerable, so patients with disabilities, patients who speak a different language, who don't necessarily understand English or have an Aboriginal background. I feel, you work so hard to develop that relationship of trust, and as soon as you restrain the patient and they're confused and they don't understand why, you lose that trust in a split second. So that's an area I find really difficult. I think the way we communicate and behave around the patient is extremely important. Even when patients seem like they're heavily sedated, I feel we really need to work around communicating with them, telling where they are, explaining, what we're doing, and also communicating with families. I think is extremely important.
Yeah. So communication, trust, all of those things that come from the framework. So it's clear that there's a thread there.
I mean, when we talk about trust, I always think back of the Danish philosopher Luke Strup, and he talks about when we deal with other people, we carry a little part of that person's life in our hands.
Wow.
And Kai Martinsen, the Norwegian philosopher, she builds on that, and she talks about our moral obligations as nurses, the power that we carry with us, and how much responsibilities are on our shoulders to look after these patients who are really vulnerable, who are weak. So, yeah.
All right. Now, we obviously want to give you a chance to talk about your study because that's a really important part of your life at the moment. So, as I mentioned, you're interested in agitation, preventing and managing agitation in the intensive care unit. Can you give us a little bit of an expansion on what you're doing and what your plans are?
Yeah, so I'm currently, me and my supervisors are developing a guideline on non-pharmacological approaches to reduce agitation in the intensive care units. And it's not to say that medication is not important. We know that it's very important to treat underlying causes of agitation, but also to sometimes keep patients safe. But it's also important that nurses know about effective non-pharmacological approaches and what is it that we can do that doesn't involve medication, because we know that there are a number of side effects often related to medication and drugs. So really looking at person-centered non-pharmacological approaches.
Yeah. So not tying people up and not giving them loads of narcotics, which would obviously involve a person-centered, relationship-based, integrated way of management. Do you think there's any special considerations? You've already mentioned about vulnerability of the patient that's heavily sedated and potentially critically unwell because they're in the intensive care unit. Are there any other implications you think of that context, that intensive care context, that would be relevant or that need to be considered?
In the context you're thinking of?
Yeah. Oh, well, I'm just thinking like the intensive care unit is a kind of unique environment. Yeah. Is there anything there that you think is really important to consider from a fundamentals of care point of view, or do you think, like you've already mentioned, these people are exceptionally vulnerable? Is there anything else?
I guess it's more around supporting all of their needs. How do we support their needs? And doing it in an integrated way. Because I think often I've done it myself. You walk in and you find all the technical equipment,
all the machines that go ping.
It's so interesting, and you have to focus. That's important as well. But we also need to remember the patient in the bed, and how can we integrate care? I think that's a real skill to be able to do that, so that when we deal with the wound or when we deal with the medication, that we also think about how we talk with the patient and how we make them feel safe.
Yeah.
Because we know that these patients often feel scared, they feel alone. And so the way we provide care, I think, is really important.
Yeah, and again, that's been the focus of your study. So tell me then, how has being a member of the ILC been helpful for you in your studies, and I suppose, what's it sort of given you, or what are you hoping to give it?
Okay, yeah. So I have been very fortunate to receive the inaugural Erik Elgaard Sørensen Scholar, which is really, a scholarship that's been developed through that collaboration between Aalborg University in Denmark and Flinders University here in South Australia. So I have two Danish supervisors and I have two Australian supervisors, and it's been really great. I think the fact that you have supervisors who are passionate about the same topic makes everything a lot easier. So even though we specialize in different areas, have slightly different interests, and perhaps my supervisors have different, skills in terms of research, we all are sort of moving towards the same aim. So the process is just much easier. And I feel that not only do I feel really passionate about that and motivated about my studies, but I feel it's reflected in my supervisors as well. So yeah, that's made it a lot easier. I think doing research across borders has been interesting. I mean, I am Danish and I'm working here in South Australia, but being able to do research across borders has just been an amazing experience. And I think it makes sense as well, and I think we can learn a lot from each other. It makes sense, if you think about the time and resources that you put into developing a guideline, it makes sense that that you don't have two different groups in two different countries developing the same thing, when potentially we could help each other and develop perhaps even something that's better.
Well, it's going to be relevant to more people. So, that's absolutely right.
And it's exciting. I mean, I've just been invited to do a presentation in Denmark at a symposium, and I feel it's great that we can share knowledge that way. So.
Well, look, thanks so much for chatting to us today. It was really exciting to hear about your study and also how the ILC can help support this kind of work. But again, and that it seems to me that it's that underlying philosophy and the commitment to that person-centred fundamental care that is giving you the support you need to get on with your study. So all the best with your studies. And again, thanks for joining us.
Thank you. Thank you very much, Sydney.